Good morning. My name is Artur Jurczyszyn. I am a physician from Krakow, from the Jagiellonian University, it's my great pleasure and honor to be with you, and thank you for invitation. It's my first time in the American Virtual Myeloma Conference. I work in the Department of Hematology. You can see here on the right, this is a place where I am every day going for the last 26 years. So this is exactly half of my life. I am a physician and hematologist in the oldest Polish university, and I focus on myeloma for many years. And my task for you is to share my experience regarding optimizing management of the high-risk multiple myeloma patients. I would like to start from the beautiful paper published a couple of days ago by Faith Davis and colleagues. The name of this paper is Perspectives on the Risk Stratified Treatment of Multiple Myeloma. And I choose 3 boxes from this paper. The first box is high-risk multiple myeloma disease segment. It's a big challenge to treat multiple myeloma with high risk. It's about 30% new diagnosed myeloma. The proportion of patients with high risk disease increase with every successive relapse. High risk disease is a significant cause of mortality in multiple myeloma, especially in early mortality. Current therapy has not significantly improved the outcome of high-risk disease. We are waiting the big progress as a standard risk. It's an aim. The biology of high-risk disease is very unique. We see increased proliferation rate, resistant to apoptosis, focal growth, bone marrow independent growth, more than one type of biology, intraclonal heterogeneity. High-risk subclones may be selected for the treatment. Treatment needs to address intraclonal heterogeneity. We have features of high-risk disease like clinical features, laboratory features, and functional features. Regarding clinical features, we have very aggressive extramedullary disease and also large focal lesions. And the most aggressive situation in myeloma, plasma cell leukemia, especially secondary plasma cell leukemia. And also we have a problem with primary refractoriness to the treatment. Everybody knows the laboratory, the genetic features. It's a beautiful paper regarding revised ESS. We have cytogenetic features like translocation 414, 1416, 1420, gain 1Q, and deletion and mutation PP53. We can also choose high-risk gene expression profile. This is the most important, and functional features like initial response to therapy with relapse in another 1 or 2 years. We have novel features like microenvironment features identified by single-cell analysis and advancing imaging. Another box is a recommendation for improving outcomes for a high-risk feature. We know that healthcare system should be recognized this importance of high-risk situation, approve reimbursement of novel diagnostic tests, and provide appropriate reimbursement policy to enable personalized therapy. This is unmet need still. Clinical and molecular stratification should be performed for all new diagnosed myeloma. Testing should be performed on purified bone marrow plasma cell. Panel should include identification of adverse translocation, translocation 414, translocation 1416, and other rare situations like copy numbers abnormalities, like gain and amplification 1Q, deletion on 1P, and of course deletion on 17P. We should be moving forward and regarding clinical, and very important is minimal residual disease negativity in such a cohort of patients. Another situation is appropriate clinical trial design for this high-risk patients. Risk stratified treatment studies using standard inclusion criteria with phase 2 studies that explore high active regimens. All-come trials were randomization of stratified based on risk to avoid imbalance. With a planned analysis of high-risk patients included statistical analysis. The methodology used to define risks should be reported, including cytogenetic, IFISH, gene expression profile, DNL panels, the percentage of cell-positive and the cancer clonal fraction of specific abnormalities. Another situation I would like to share with you a paper published together with my PhD student regarding multicenter retrospective analysis of 23 patients with high-risk feature translocation 1416 in myeloma. And the take-home message from this paper is that based on this largest report, quarter of the subset of myeloma initially presented with renal failure, and also old age and area C3 predicts poor survival. And median follow-up in this project was 4.1 year, and the PFS and overall survival from first-line therapy were 2.1 year and 1.1 year respectively. This is quite a rare situation because translocation 1416 is found between 3 and 5% of new diagnosed patients, but it's still unmet needs. Another situation regarding features of in clinical situation is primary refractoriness on proteasome inhibitors and immunomodulatory drugs, and we published a paper a year ago regarding the situation with 85 cases, and it's still unmet needs. The best situation is when patients achieve the most benefit from autologous transplantation performed immediately after first-line induction therapy. We have predictors for progression-free survival, serum beta-2 microglobulin more than 5.5, autologous transplantation and response to second-line treatment, and also predictors for overall survival like elevated serum LDH. Also, as you see on the right, it's a beautiful paper published as a brief report in British Journal of Hematology by Graham Jackson, Jean-Luc Orizel, and Mohamed Mokhti, that early relapse after high-dose melphalan autologous transplantation predicts inferior survival and is associated with high disease burden and genetic high-risk disease in myeloma. This is very important to choose the best optimal therapy in such cohort of patients. We have importance on individual cytogenetic assessments. In the HOVON trial, early autologous transplantation with bortezomib maintenance led to similar outcome in patients with standard risk and high risk, as you see here in this box. Another situation, would patients benefit with other conditioning regimen? We should think what is the best conditioning regimen. We know that MEL200 is the best option and the most popular, but maybe busulfan it's better. As you see here, a paper published 3 years ago, high quality evidence of progression-free survival benefit from BuMel compared with standard dose of melphalan 200 as a pre-transplantation conditioning in myeloma. But of course, we should know that BuMel is much more toxic. As you see here, mucositis grade 2 and 4 and neutropenic fever grade 3. It's much more common in the patients in the arm with BuMel. Conditioning therapy with BuMel before autologous transplantation yields significant longer progression-free survival, but we should know about also adverse events. I think the most important in this cohort of patients is quadruplet regimens as induction therapy. High-risk patients should benefit, and we know that it's the most important to give him a DARA-KRD or DARA-VRD or DARA-ERD or anything with quadruplet therapy. This is the most important and the most effective in many trials. It was a comparison. I would like to share with you with master trial. It was beautiful trial published by Luciano Costa, induction therapy with DARA-KRD, 4 cycles autologous transplantation, 2 times consolidation with DARA-KRD and land maintenance. This is important that minimal residual disease assignments after each treatment phase, patient with confirmed MRD negative status entered as a free observation in this trial. In this cohort of patients, we see here the patient characteristic that's high-risk feature, including 1Q, was more than 50% in the enrolled patients. And the beautiful the results, rapid response with a high proportion of patients achieving complete remission and stringent complete remission in both standard and high-risk group. As you see here, patients with high-risk group and standard are very comparable in this after this beautiful therapy. This is the best minimal residual disease response by phase of therapy, and this is a comparison typical in standard and high-risk group. This is a progression-free survival and overall survival, and the conclusion is that effective novel consolidative strategies should be explored to clear minimal residual disease and novel improve outcomes in patients with ultra-high-risk patients. This is another trial, very similar, but German Katja Weisel published it 2 years ago, that isatuximab plus KRD and later autologous transplantation, consolidation, and maintenance has beautiful data. It's 100 patients with high-risk features, and the efficacy is very nice. Minimal residual disease status, more than 60%. ISA-KRD induction induced deep response in high-risk group multiple myeloma patients with high number of minimal residual disease negativity. We know that addition of monoclonal antibodies to a backbone triplets is very important. It's the trial like Alcyon and Cassiopeia that prove that DARA-VMP or DARA-VTT has very nice results, and until we have clear overall survival data, potential new quadruplets should be reserved to transplant eligible patients. And what about tandem transplantation? We know that in STAMINA trial, after autologous transplantation, it was randomization to land maintenance, all autologous transplantation and land maintenance, all consolidation, VRD, and land maintenance. And a paper published 2 years ago by Dr. Hari analyzed what is the results in this trial. And as you see here, standard group risk and high-risk group patients who received only a maintenance therapy, it's not the best option. The best option is doing auto and auto-allo in this situation. This is a paper published by Nico Gagelman in Biology Blood Marrow Transplantation, autologous transplantation for extramedullary disease in multiple myeloma. You see here patient with standard risk and high risk was more than 40%. Data, very big database, more than 600 transplant centers located mainly in Europe. And after this analysis, post-transplant outcome, we know that overall survival appeared to be affected by transplantation, showing higher response for auto-auto or auto-allo than single auto transplantation. This is very nice that overall survival was significant better in patients with standard risk than in high risk. So these patients should be offered tandem transplantation. We see here that after autologous transplantation, overall survival was the same for high risk and standard risk group. Another paper was published by Michele Cavo, analyzing also EMN trial and 5 years survival in high-risk cytogenetic group and 5 year overall survival in deletion 17 positive group. And we know that auto-auto is the best option than single auto. This is very important. Study failed to show advantage of tandem transplantation We have a European study, but we know that patients who has high-risk feature should be offered this. This is my project published a couple of years ago regarding also rare situation and rather aggressive type of myeloma like skin infiltration. It's a rare situation, and plasmacytic infiltrates typical, present as a red violet spots, nodules, lumps. The most common location, chest, lower extremities, back, and backwards. All patients, it was 53 patients from 24 centers from 13 countries in Europe and Americas. And we don't know how to treat such patients, but overall survival is rather poor, like 8.5 months. And also patients with plastic features had the worst survival, and the worst survival is patients with IgD and IgA myeloma. Also, rare situation in myeloma is CNS involvement. The central nervous system was a rare situation. Patient usually present with focal neurological defects, changes in vision, radiculopathy, headache, and we don't know how to treat such patients. And we collected 172 patients, daily clinical practice published in American Journal of Hematology, and the overall survival in this unmet need group is 6.7 months. The best situation was when you treat with systemic therapy, chemotherapy, and radiotherapy, and the best to offer autologous transplantation. Also, our trial published 3 years ago with Irit Avivi focused on hematogenous extramedullary relapse in myeloma, multicenter retrospective analysis in 127 patients. This is a characteristic of these patients, and the take-home message is that it's probably the best option is immunomodulatory drugs, but the overall survival after such situation is only 7 months. On the end, I would like to share with you with beautiful data from Martin Kaiser Optimum trial. It was published last ASH in a patient with high risk and also with primary plasma cell leukemia. This is the digital comparator trial, DARA, very intensive treatment with daratumumab. And the summary is very nice results in these ultra high risk patients, high deliverability or subcutaneously oral only regimen. Safety data shows manageable side effects, anticipate consolidation therapy, and patients. It will be updated probably in another ASH meeting. And this is my high-risk patients, patient born in 1964, professor of astrology. He was diagnosed with IgA multiple myeloma, December 2019. High-risk feature, FISH translocation 414, first-line therapy, VTT, it was thalidomide intolerance. We switched for cyclophosphamide, bortezomib, dexamethasone, another 4 cycles completed on June 2020, VGPR July, mobilization RRC plus GSF, and we offer for him tandem transplantation. Another was maintenance therapy from June 2021 until now. I showed him a couple of days ago. He's in very good condition. This picture was done on March in Polish Tatra Mountains in a ski tour. He's much better, to be honest, than me. So, as a conclusion, despite of recent treatment advances, patients with high risk and ultra high risk myeloma continue to have poor clinical outcomes. We should collaboration between physicians, study groups, pharmaceutical partners, patient groups, trial sponsor, and regulatory organization, because we wait to achieve such beautiful nice like we have in standard risk group. This is a take-home message that there is a high-risk multiple myeloma beyond common indexes. So far, no prospective study of specific extramedullary disease treatment has been published. Organ involvement has worse prognosis compared to paraskeletal involvement. Extramedullary relapse is terminal pathway in multiple myeloma. since the disease is associated with high-risk feature, should be treated as a high-risk situation. Some patients with myeloma become diagnosed with plasma cell leukemia. After a paper from Thomas Jelinek, it will be probably 2% in blood as a cutoff for plasma cell leukemia. It's a clinical presentation. For patients with eligible for high dose therapy, the best is triplet or quadruplet induction followed by the best tandem transplantation. For patients with ineligible situation, the best option is quadruplets with DARA plus VMP or DARA plus RVAD. At relapse, there is no rationale to favor specific therapeutic plugs. Always consider radiotherapy in special situation, and for CNS extramedullary myeloma, consider the combination of systemic therapy, intrathecal, and sometimes autologous transplantation. Thank you very much for your attention.